Okay, well, thank you so much, Dr. Van Stone, for the introduction, and thanks to the stewardship team for the invitation, the opportunity to meet with you. I do see some familiar faces. I see some new names out there, and I do see some folks to whom I have not yet had the opportunity to share some of this information with. For some of you who have been here before, there'll be a tiny bit of new stuff, lots of review. Hope that you can appreciate the review in the sense that this is like a muscle and you need to keep working it out even if you do the same exercise, exact same exercise in succession. It can still have benefits, and I think these are concepts that are constantly attacked, and and encroached upon by marketing and hype and stuff like that. So I hope I can refresh a few of those thoughts for you here today. The slides are as long as the title is, so I'm going to go fast through a few parts, but I'm also expecting a little bit of interaction. And I've got my chat box open. I'm going to be watching the chat box to see your responses to some of these questions, and I'll try and keep an eye on things too, just in case there's any technical challenges. Okay, financial disclosures that I need to make. I don't have any. I don't have any relationships with commercial interests. Um, that this particular presentation didn't get any financial support, in-kind support of any kind. I do want to make the disclaimer, and I've shared this with a few folks before. I'm not an there. There's only one advanced degree in evidence-based healthcare that you can get there in the world. It's at Oxford University in England, and lots of potential barriers for me to get there and study that. So I can't actually claim to be an educated expert, but I just am a big geek about evidence-based medicine and critical appraisal. Think about this stuff all the time. I dabble in it constantly. I have the opportunity to work with the RX files and be exposed to all the evidence-based medicine work that they're doing. I do an EBM mentorship program and a stewardship program where I work one-on-one or with small groups of folks on critical appraisal, and that keeps me sharp and it helps spread the good word about critical appraisal. Saskatchewan Health Authorities give me lots of opportunities to work with pharmacy residents and the Faculty of Medicine, Family Medicine, working with their family medicine unit as well in critical appraisal. Lots of other experiences I won't go into the details of here and now, but just so you know, I do work at this, but just want to express that I'm not an expert. Now, when it comes to mitigating potential bias, I need to acknowledge, it's easy to say because I don't have any financial, commercial interests or anything like that, that I might not have any potential bias. But as you should hopefully start thinking, and this is what I hope to do more than anything today, is just cause you to have some doubts and the thoughts of doubt. Is that not anybody is really free from bias? Just a reminder about that. And you know, our personal experiences make up some absolutely tiny fraction of what's ever happened in the world. But gosh, does it ever have an impact on how we think? And we won't have a lot of time to get into how we think here today, but I'll try and give you some tools that you can use to overcome what is human nature. So I do have some biases. I'm aware of some of them. I'm not aware of all of them. You might learn some of mine, and I just ask you to start to think about, do you have any biases and what might they be? A prominent Canadian physician, Sir William Osler, once said, "We are misled by the ease with which our minds fall into the ruts of one or two experiences." So start to think about what might be some impactful experiences in your life that could shape the way that you feel about healthcare and different interventions. So there's that. There's that aspect that we all have these biases. There are also situations where we've thought as a healthcare community, gosh, that this particular intervention makes a ton of sense. But as Dr. Forrester reminds us, there are things in medicine that make perfect sense but are wrong. And I've got a big long list here: vitamin E to prevent heart disease, estrogen to prevent heart disease, lowering hemoglobin A1C with different medications, lowering blood pressure with certain medications. We can fix numbers, but we can't always fix the outcomes. Sometimes we're wrong about things. And then I just have a general comment here. about all those different interventions that we heard about for COVID-19. I'm going to go through a few of them today. A lot of this stuff ends up being wrong, and we're going to talk about why it ends up being wrong. Our learning objectives, I'm hoping by the end you'll be able to describe techniques for critically appraising literature and explain the rationale for critical thinking when reviewing literature. And so we're going to do that by reviewing critical appraisal techniques. I also want to, my personal objective is to potentially embarrass a couple loved ones on the line. I'll start right there. Kelsey Dumont, I have a crush on you if you're on the line. And I just found out that my sister's on the line too. So hi, Jessica, and thanks for tuning in today. I hope I embarrass both of you a little bit. Okay. Now, how we're going to get there, we're going to talk about the impetus, and then we're going to go through the techniques for evidence-based medicine and critical appraisal. So the impetus. Couple examples, 3 examples I got for you right off the hop here. First one is remdesivir in the setting of severe COVID-19, and the claim at that time was clinical improvement was observed in 36 of 53 patients. Okay, so just hold that thought for a minute. Remdesivir, clinical improvement was observed in 53 patients. Tocilizumab improves survival, one thing that we learned from the recovery collaborative group. We also learned that there's other medications that are being developed. Molnupiravir, for example, stops COVID in its tracks. Okay, so just hold those thoughts. These are headlines. These are like big news stories, late breaking evidence that's coming out during the COVID pandemic, and just be aware that we're going to come back to these. Don't necessarily need to remember any details right now, but just think about some of these things. Okay. So we've got all this late breaking evidence, all of this, all these headlines, all this hype, all this marketing that's occurring, driving us to make interventions. And I can tell you, as somebody who works in the healthcare system and someone who's involved in, implementation of formulary decisions and stuff like that, the demand for those medications was extremely high, remains extremely high in some circumstances. And that's that pressure to have those drugs available for the provision of care constant. But there's also the 17 years problem. The 17 years problem, if you're thinking of the 17 years problem that I'm thinking of, it actually kind of is counter to the fact that the demand for all these late breaking interventions is really high. And the issue is that there's a significant research to practice gap that's been identified for a number of decades now. We've been aware of this, that you can have really good evidence, and it actually takes up to 17 years for some of that evidence to actually make its way into clinical practice. So we have to kind of balance and entertain both ideas at the same time, that we have huge demand for interventions. At the same time, it's really hard to get evidence into practice. Okay, we're going to get interactive here. Pop quiz. This is some later data. If I were to ask you, what were the top 5 non-chemo, non-biologic prescription medications in Canada in 2022 by total program spending? So non-chemo, non-biologic prescriptions. Just toss your answers into the chat box. What are you thinking top 5 prescriptions by total program spending might be? Amoxicillin or amoxicillin, okay. Statins from Julia. Oh, hi, Julia. Wow, cool. Kristen says PPIs. Dylan says SSRIs, metformin. All right, lots of good answers coming in here. Yeah, opioids, Dylan saying maybe, who knows? Okay, I'm going to show you because this wasn't for marks. The answer was direct factor 10A inhibitors. So just as a heads up, this is a relatively new class of medications in the last 10, 15 years or so. So when they're relatively new, they tend to be under patent and they're more expensive. So rivaroxaban and apixaban and edoxaban are the ones that are available in Canada, probably constitute this class of direct factor 10A inhibitors. Those are anticoagulants, prevention of stroke or treatment of pulmonary embolisms and DVTs, basically trying to prevent clots from forming or getting worse. So that class of medications is right up there. They were expensive. They're under patent. Not a big surprise. GLP-1s or glucagon-like peptide analogs. These are your weight loss drugs. Sure, you could consider them that. They're also the diabetes medications, relatively novel diabetes medications, though they've been around for about 10 years now too. Again, largely under patent. And expanding indications. So not just for diabetes anymore. We are seeing indications for folks to reduce their cardiovascular events if they are obese or overweight. SGLT2s, another relatively novel class of diabetes medications to lower your blood sugar and improve your hemoglobin A1C. Antipsychotics, just a broad group of other antipsychotics here, and statins. So the hemagglutinin coenzyme A reductase inhibitors, or statins, simvastatin, atorvastatin, rosuvastatin, probably constituting most of this class of medications. Somebody had mentioned that. I think Julia was somebody who mentioned that earlier. Okay, so that's top 5. If I were to ask you the top 10 medications in 2022 by total use, even quicker this time, what would you say top 10 medications just by total use? And if you've, maybe we can reuse the same list we got there, but if you got other thoughts, go for it. Again, SSRIs or statins, yeah. So we just think that everybody's on statins, probably everybody's on PPIs, probably. Okay, SSRIs again, yeah. I won't go through the whole list. Thanks, Catherine, for bringing up amoxicillin again. ACE inhibitors, yeah, so statins again here, PPIs are there. Calcium channel blockers, another medication that's often used for blood pressure reduction, maybe a little bit of cardiovascular risk reduction, calcium channel blockers, amlodipine, etc. ACE inhibitors are on the list. Somebody mentioned that right at the end. Corey, thanks. Penicillins with extended spectrum, and that actually qualifies. That's where your amoxicillin starts to fit in. We have beta 2 agonists, and I'm guessing those are things like salbutamol or blue puffers, blue inhalers, right? Beta blockers, SSRIs, I think Dylan had mentioned that. That's one that comes up here. Thyroid medications, lots of folks are on thyroids, and then antidepressants as a general category here. So that's, there's nothing to this. There's no marks or anything like that. It's just to start to think about this particular concept, okay? That's what I wanted to start to think about, is that compared to hospitals, or next to hospitals, I should say, and compared to everything else, drugs have now become the second highest healthcare spending in Canada. As of 2017, so 5 years previous, the drugs was number 3 behind physicians, but it's now number 2. So it is the second biggest cost. Huge business. This is big business. And so that's lots of dollars are at stake, and drug therapy just is not easy. There's these intense pressures to prescribe. Remember all those headlines saying you got to prescribe remdesivir, tocilizumab, or molnupiravir? There's all those intense pressures to prescribe. We have patients who demand treatment. They say, give me something or I'll die. We have peers who say, you're not using intervention X already. What's wrong with you? So all of these different pressures coming at us from all sorts of different angles. We have all these new agents introduced at unprecedented rates. Information regarding total drug cost is really hard to find. So yes, it's one thing to pay for the drug when we think about what the drug might be causing as far as hospital admissions or reduction of hospital admissions or required lab work and monitoring or nursing time, all of those considerations. That information is just really tough to calculate, and it comes down to subjectivity and weird ways of doing those calculations. Ultimately, it's difficult for healthcare providers to keep up. Remember, we're healthcare providers getting all those same headlines all the time. Plus, we have the 17-year gap between when research actually gets into practice, meaning that I think there's actually about 25,000 articles published a year just in healthcare alone. What we end up seeing is older drugs being passed over for newer drugs. Drug costs go up, and we deviate from evidence-based medicine. So that's why we're here today. That's our impetus. And it's our key clinical challenge is how do we get evidence and science into practice? Okay, so one possible strategy for this, I think, for getting evidence into practice is improving or reinforcing health evidence literacy. And I hope that's why some of you are here today. Maybe you need to improve your skills. Maybe you just need to reinforce and have your skills validated. I don't really care. Literacy could be better writ large. Okay. You might to start here if you're talking about improving health literacy. This is the evidence arc. We're going to go through this sort of piece by piece. Before we get there, I'm going to give you a quick case. I apologize for those of you who've sat through this before. I have abbreviated it just so that it's a little bit, we can go through a little bit quicker. But let's just agree for the sake of this discussion that there's a type 2 diabetes epidemic, okay? And we could also agree, someone just unmuted, anything in particular here? Okay, I'll keep going. We could also just use this information. Generally occurs in older and often obese sedentary individuals. It's associated with complications and nothing to scoff at here. Macrovascular complications, those big bad things like heart attacks and strokes, and those can ultimately lead to death, as well as microvascular stuff, which is nothing to scoff at either. Neuropathy, pain, peripheral neuropathy, which can cause pain and all sorts of complications associated with that pain or numbness, might not even realize that they have an injury, and which can increase the risk of infection. So all those microvascular complications, risks to your eyes and your vision with retinopathy, risk to your kidneys, going on to unfortunately have kidney failure and have to go into diabetes with nephropathy. Ultimately, diabetes is diagnosed by fasting glucose or hemoglobin A1C or a glucose tolerance test, different ways of diagnosing diabetes. Those are just some facts about diabetes and the epidemic. So let's say we have a 57-year-old man presenting to you as a healthcare provider or presenting to your clinic where you support healthcare providers. That's okay too. The individual has a positive family history for cardiovascular disease, doesn't smoke, does moderate regular exercise, is not obese, and has a balanced diet. He's thinking of taking aspirin or statins for cardiovascular protection. As you saw from the prescription data, statins are commonly taken, very easily has family members or neighbors or somebody else on a statin who says, hey, you should be on this. Why aren't you on this, right? You can see the pressure that this individual feels as someone who has a positive family history for cardiovascular disease. Routine testing shows no hypertension, no dyslipidemia, no cholesterol problems, but a fasting plasma glucose of 6.5. So a little bit of glucose intolerance, maybe some concerns about diabetes. And so you might be thinking your clinical question here is really what this guy's asking me is what medication interventions could be made by this individual who's middle-aged, moderately active, non-smoking, positive family history of cardiovascular disease. That's one question you might be thinking, or you might be thinking that the person is asking. And this just is the reminder to always try to do a PICO, right? We do our PICOs in order to ask good clinical questions. And lots of refresher here, lots going way back, but P stands for patient or population, and the intervention being I, control or comparative being the C, and outcomes being O. So my question for you is, this was our clinical question. How might you improve our clinical question with taking into consideration the PICO? And you can just use the chat box if somebody wants to take a stab at the PICO question, or maybe it's easier to unmute and share what you think of some tweaks that we can make to our clinical question would be. Okay, Jason's got one of the most important questions. So yeah, what's he actually trying to accomplish? Is he trying to be on a drug? Probably not. Is he trying to lower his risk of cardiovascular events? More likely that's the case, right? So what outcome is the patient looking for? Really important question. And we would want to add that as part of the O in our PICO. Okay, so just a reminder that PICO is a tool that we can use to ensure that we're asking good clinical questions. Remember, we have all these biases, all of this confirmation bias that can occur and skew our thinking. We want to be systematic in our approach to things. So it's a really good idea to write stuff out in PICO. There's a little bit of a tweak to PICO that's been made over the years, and it's become the PICOT or PICO TT is another way to think of it. And some other things is you might be thinking about how long of an intervention do we actually want to be undertaking here. Um, and it might become important in a moment here as to why this question is so important. But uh, um, we're not looking for this person maybe is looking for something really quick and easy, or maybe they're willing to do something long term, right? We might be thinking that way. We also might start to think about what kind of study are we interested in. And I think the type of study, if you're asking that question, what study are we going to look at to try and answer this patient's question? I think it really depends on the degree of certainty that you need as a healthcare provider or those who support healthcare providers, and how much time you have to search for it and read it and everything. Because if you need to be really, really certain, you don't necessarily want to just go reading a bunch of headlines and titles from studies, right? You need to actually dig into the evidence. Or if this person's just going to do an intervention anyways, and you don't have a lot of time, maybe you don't need to dig too deep in there. It depends how much certainty you need. As a refresher, remember that these are some of the different study designs and randomized control trials. If you look at pure scientific method, randomized control trials are at the top of the list because they have the increased validity, and they have increased validity because they have a reduced risk of bias. We're going to go through some of the things that can increase the risk of bias as we go down this list and look at observational studies, for example, or when we just have case series when there's no comparator whatsoever, and case reports where we're just looking at an individual patient. So we'll quickly look at those things that can increase the risk of bias and decrease the validity. But just remember, we might be, we need some degree of certainty, so we're probably going to look at the top of the evidence-based medicine pyramid. Again, randomized control trials are not the very top. They actually come in behind systematic reviews and meta-analyses, though there are flaws with systematic reviews and meta-analyses and systems and guidelines and stuff like that that you can also see at the top of depending on the evidence pyramid that you look at. So all this to say, we want to have some degree of certainty for answering this person's question. So you go out and you're doing some searching. I'm going to ask you to hypothetically pretend that you came across this study. It was the DREAM trial, okay? And the DREAM trial was actually quite old now. It's back in 2006, almost 20 years old. But it's called the DREAM trial. And like that, gets us a little bit excited, okay? And we look at it, we see the effect of rosiglitazone on the frequency of diabetes in patients with impaired glucose tolerance or impaired fasting glucose. That's this guy, a randomized control trial. Okay, so we found a randomized control trial, like a good piece of evidence. And it's looking at just like a single intervention, rosiglitazone. And if we read on, we want to see what it's going to investigate as far as outcomes go. And we want to assess prospectively the drug's ability to prevent type 2 diabetes. Remember, type 2 diabetes causes all those macrovascular and microvascular complications. Okay. And this is how the study was set up. They screened 25,000 patients. That's a lot. That's a lot of patients. They then randomized people into two different groups. There's a little bit of a red herring on here because they did a concurrent study looking at an ACE inhibitor intervention. But if we just look at one group, half of that 5,200 patients got rosiglitazone, and half of 5,200 patients got placebo. Okay. They then followed them for 3 to 5 years, and they measured their outcomes. Okay, so here's an intervention that this guy could do. He's in your office. He wants to know what he could do to prevent his risk of heart attack and stroke. And now you got this medication that might be preventing diabetes. Isn't that exciting? Okay, but we have to get to the appraisal. So start to think about what are some of the things that you would ask to understand whether this trial can be trusted or not. I'll ask you to use the chat box type or unmute if you feel comfortable unmuting. What are some things you start to ask? Could I trust that study, the DREAM trial? Conflicts of interest, okay, yeah. So we might suspect that the study is probably sponsored by the manufacturer. How old is the trial? Okay, so again, it's almost 18 years. It is 18 years old now, and so your patients might be different. Yeah, so you might start to question whether or not patients are similar in 2024 that they were back in 2004. Melissa's bringing up issues of blinding. Christine, I believe it's probably Christine Lee, is asking about randomization. Catherine Neal asking about primary endpoint. Doesn't matter to me. Awesome. I'm so glad you're thinking all of these things. And this is Zach's checklist of things to ask just on, can I trust the findings of this paper? Because if I get concerning answers in anywhere in this list, I trust the trial a little less. And if I get a bunch of concerning answers with this list of questions, I will actually suggest that we don't bother going on to read what the study found. It's not valid, and therefore there's no utility in actually going on to read. So let's quickly fire through these things. Did they do these things in the DREAM trial? Did they randomize, and did they do so in a concealed way? And I'll just show you right here. Patients were concealed, or randomization was concealed, which means not only did patients not know what group they were going to, the people who were recruiting them into the study did not know what group they were going into. It was a completely concealed process. That's extremely important for study validity, because if people know what group someone might go into as they're being recruited into the study, they might actually be encouraged to recruit them into the study because they know you're going to get that intervention. Or they might be discouraged from recruiting into the study because they know you're going to get placebo. There's all sorts of bad things that can happen and have happened because of the lack of a concealed randomization process. So you want to make sure that randomization is done in a concealed way. And it's different than blinding, okay? This is all before the study actually starts. You want to make sure that group A, prognostically speaking, looks very similar to group B, okay? So they did good there. That's right from the study. This is an excerpt from the study. How about blinding? Really quickly, again, because they used a placebo, you can assume that there were certain groups that were blinded, probably patients, probably healthcare providers. And if you read the supplementary materials, which have the study protocol in it, you would see that they used placebo and that those folks were blinded. Otherwise, what's the point in using placebo? So they blinded them. Here you can read that there was mass adjudication. So people who were collecting data in the study also didn't know whether someone was getting the study drug or not getting the study drug. So even the diagnosis of diabetes itself was being done in a blinded way. So I'd give pretty good marks to this study for blinding. The only question mark really is around data analysts. We don't have to get into that detail today, but pretty much they blinded everybody. Now, what about loss to follow-up? Meaning, if we had Group A made up of 2,600 patients and Group B made up of 2,600 patients, how many people did we actually follow to the end? Because if we only followed a certain proportion of those patients, and there's some patients who went away, we don't know what happened to those people who went away, and they could skew our results. But ultimately, we want to include them in the findings so that we can maintain that prognostic balance. All the work that we did to randomize and make sure that the two groups look the same, we want to make sure that they get analyzed that way too. So we have to look at how many people they randomized, about 2,600 patients into each group, and that's how many they analyzed in each group. So that's awesome. That's a good sign. I'm giving them more top grades for this particular study conduct. Okay, they did a good job. I ask you now just to think about, what is the likelihood of bias in this study? I just told you, like, from a hopeless, that there's, high likelihood of bias or low validity. It's just a hopeless case. We shouldn't bother reading on one end of the spectrum, whether it's perfect study 100, they got 100%, they did everything right. Yeah, I'm at this end of the spectrum, just from a validity standpoint. Was the science good? Yeah, the science was good. But something is important. Something else is important, and what that is what we're looking at here is a composite primary endpoint. Okay. Now that composite primary endpoint is made up of a couple different endpoints, not only death, okay, but also the establishment of diabetes. And you can actually break down further cardiovascular endpoints from this particular study, looking at myocardial infarction or heart attacks, strokes, cardiovascular death, heart failure, angina, revascularization. Okay, all these different interventions once you start to break them down, there's actually very few of these intervention or of these outcomes, pardon me, that have a statistically significant finding. Okay, that's one of the reasons we do a composite endpoint is you have to study a whole bunch of people in order to find out whether a difference is made. When we do a composite, we can combine all those different outcomes and have almost like a meta-analysis within a randomized control trial. So composite endpoints aren't necessarily a bad thing, but there's a tricky competence endpoint that was used in the DREAM trial, which we're going to get to here. But if you had to guess, what were the authors concluding? Were they saying that this drug, rosiglitazone, to prevent diabetes should be used for all patients, for some patients, or no patients at all? And we're running low on time already, so I'm just gonna, yeah. So Jason's saying, they're probably going to suggest that it's for everybody. But I'm asking you, what is your view? And because you're good critical thinkers already, you've already got some of those thoughts in the chat box here related to patient important outcomes. I'm going to suggest that we are maybe thinking that it's closer to this end of the spectrum, B or C. And what's gone wrong here? These investigators are smart people. If you look up the list of authors, they're highly credentialed. They've published multiple studies in some of the largest journals in the world. So what is the problem? The problem ultimately is that the development of diabetes is a surrogate. Okay. And it's a surrogate for all sorts of bad stuff. So I don't want to be completely dismissing it. It can cause death. It can cause cardiovascular events, all those other things we talked about. But it's a surrogate at the end of the day. And we know that there are interventions that can prevent diabetes, but unfortunately don't go on to prevent other bad outcomes. And that actually is, rosiglitazone is an example of that. Yes, it prevented diabetes. Only 10% of the group, 11% of the rosiglitazone group got diabetes, whereas in the placebo group, 25% got diabetes. But when we start to look at cardiovascular, or when you just look at death alone, there was no statistically significant difference in death between the two groups. So we're giving this drug for 5 years, but we're not reducing death at all. And when we looked at all those cardiovascular endpoints, you might remember there was no improvement. So we use surrogates often. We have to use them. They're biologically compelling. There might be an observational study that suggests there's an improvement with a particular surrogate outcome, and therefore we might assume that it causes improvement in a patient-important outcome, but not always. But they are sometimes compelling also practically. We have to do it. We can study things for a shorter period of time, but we have to be cautious that there are drugs that fix our numbers all the time, but unfortunately, they don't improve outcomes. And ezetimibe is another example, fixes LDL, hardly fixes cardiovascular endpoints. Doxazosin is another example of a medication that reduces blood pressure, doesn't improve cardiovascular outcomes, or not to the same degree as other interventions. So we want to fight for these patient important outcomes to be considered in our literature. And when we have marketing coming towards us and hype coming towards us as consumers of health information, we want to demand patient important outcomes. And we should only accept surrogate outcomes if it's really strongly associated with improvement in a patient important outcome. And we might just say it might mandate changes in those particular circumstances. Lots of different examples of surrogate outcomes versus patient-important outcomes that are out there. Again, we're fixing numbers when we're looking at surrogate outcomes, but is it actually fixing the outcomes that patients care about? Okay. Okay, so here's last thing on the DREAM trial. What we ended up finding out is that this drug also had a statistically significant increase in heart failure and caused heart failure. And now that drug is basically inaccessible, not completely inaccessible, but practically inaccessible. Okay. So we love randomized controlled trials. They also have their limitations. Oftentimes your patients were excluded. So Leslie Penner, I think earlier had mentioned, this was almost 20 years ago. Our patients are likely different 20 years from then. But sometimes they are just excluding patient populations from their studies because they have comorbidities that they're worried will conflate the results of the study. So you need to ask, this worked in this particular study. Would it work in my patients who might have depression or anxiety? We also need to be careful when interventions are compared to nothing or to an inferior comparator. That happens, unfortunately, all too often, where we're comparing something to placebo when there's already another existing intervention out there. And that happened quite a bit in the diabetes world, actually. And then we need to be cautious with outcomes that don't matter to our patients, like surrogates. So the moral of the story is beware surrogate outcomes. The science was fantastic. The numbers were impressive. The applicability was a big problem. And if an intervention is harmless, there's no cost, we can probably rely on a surrogate. But if the intervention has harms or costs, like heart failure or taking a drug for 5 years, we should demand evidence of effect on patient-important outcomes. So then we use critical appraisal as consumers of health literature in order to help us practice evidence-based medicine. Okay, so we can use those tools. My approach, take it or leave it, just to sort of summarize some of the tools that we can use. There's these three overarching questions. We just talked quite a bit with the DREAM study about the quality of trial methodology. And you might be thinking about the risk of bias being a conflict of interest. And somebody had mentioned that earlier, that the conflict of interest is there. This is actually different. Bias is the introduction of systematic error. It's different than conflict of interest. We'll talk a little bit about conflict of interest at the end. But there's those three main considerations: randomization, how, and was allocation concealed? Who did they blind, and did they follow up? Did they do follow appropriately? Did they do an intention to treat analysis and study everybody that they said they were going to study? And if we go back to that remdesivir study I showed you right at the very beginning, a big problem, we probably don't have time to go through what was the problem with this study, but if you had looked at the details, we'd say that what the claim was that there's clinical improvement observed in 36 of 53 patients, okay? And hopefully now, as you look at that again, you are seeing that the problem is that there's a randomization violation here. So a big paper published in the New England Journal of Medicine didn't have a control group, and there was no randomizations that had occurred. So some patients got better during the study, absolutely. In fact, 68% of patients got better in the study. But would they have gotten better without the medication? That's the big question, and we have no idea because there was no control group. So we have to be cautious, even when we're reading big studies in the New England Journal of Medicine. And this isn't even the biggest or clearest example of lack of randomization causing problems. There's other situations where we have unconcealed or open allocation. So we're actually picking who's going into which study groups. And as you can imagine, with human nature, with all of our confirmation bias, with our good intentions, we can manipulate the heck out of a study and the population that's being studied. So we got to be cautious with that. And then this happens all the time. Observational studies, one of the reasons that they introduce bias is because they're not randomized. So group A probably has a different prognosis than group B. And if they have a different prognosis than group B, it's very difficult to tell whether or not an intervention is actually making a difference because they didn't have the same prognosis in the first place. What are the results? Just to quickly cover off some EBM math, there's two main considerations, and we want to think about how large or small the effect was. We can have statistically significant findings, right? But just because it's statistically significant doesn't mean it's clinically significant. Would a doctor or a patient actually care about this intervention? We have lots of situations where studies have proven to be statistically significant, but not clinically significant. And we also need to balance benefits relative to harms because unfortunately, in most published literature, the focus is on the benefits associated with interventions, and there's there's the ignorance of the harms associated with the intervention. And then we can look at some things to determine the precision or the trustworthiness of the effect. We can look at things like confidence intervals and lines of no difference, and whether something has a really wide confidence interval in a forest plot, for example, that would be a sign that's not a very precise finding, and that we need to be less certain that we had a trustworthy answer. Okay, so just jumping back to this tocilizumab example, they said that it improved survival. And I'll give you the upfront disclaimer. It actually, in this particular study, early study, it did improve survival. When they looked at the 2,000 or so patients, 31% of patients were allocated to tocilizumab died, versus in the control group or the usual care group, 35% died. And that's a relative risk of 85%. And the confidence interval is 76 to 94%, and it's a statistically significant finding because the p-value is less than 0.05. If we did a relative risk reduction, so we could say it reduces the risk by 15%, the risk of death by 15%. But we need to be cautious because relative risk inflates benefit, and it also is ignorant of the risks associated with a particular intervention too, right? The absolute risk reduction, if you just subtract 31 from 35, you get an absolute risk reduction of 4, which means we have a number needed to treat of 25. So for every 25 patients we treat with tocilizumab, 1 life will be saved. And that's actually pretty impressive. My question for you, though, is that's actually, like, admittedly very promising because it's a mortality reduction. We need to be aware, too, though, that 24% of those people will receive no benefits, but they do get the side effects. But my question for you ultimately is would you accept a number needed to treat of 25 for something like a headache or a sore throat or heartburn, where you have to treat 25 people with drug X in order to reduce their heartburn in one person, and 24 other people don't get the improvement, but they do get the side effects? And that's where our EBM math literacy becomes really, really important. We want to never just look at relative risk reduction. We want to be considering it in concert with absolute risk reduction. And these are all examples of 50% relative risk reduction and the corresponding number needed to treat. Like if you looked at Imitrex for migraine relief at 2 hours, number needed to treat of 2. For every 2 patients we treat, we get migraine relief in 1. Or if we talked about the risk of moderate bleed with ASA or with ASA plus clopidogrel versus ASA alone, number needed to harm of 125. Vioxx, or a medication that we used to use, rofecoxib, for pain and its likelihood of causing GI complications, number needed to treat of 129 if we used it instead of something like ibuprofen or naproxen. So just to say, these are all 50% risk reduction or risk increases when we talk about it in relative terms. But when you look at absolute terms, you got to treat a whole heck of a lot of patients in order to avoid certain outcomes or in order to get the preferred outcome in one patient. Lastly, how do we apply these results to our patients? My recommendation is always just go back to your PICO. Think about whether these patients actually represent you or the patients you see, whether the intervention is even possible. The drug we're going to look at in a moment here, molnupiravir, isn't even available. And the comparator, do they use the right comparator, is really important, and the outcomes ultimately. Do my patients or do I even care about these particular outcomes? So this was the last headline I showed you right at the very beginning. This 5-day course of molnupiravir seems to stop COVID in its tracks. But by the way that they determine this is by day 3, 28% of patients in the placebo arm had COVID in their nasal pharynx compared with 20 patients receiving any dose of molnupiravir. So fewer patients had the virus in their nasal pharynx. And ultimately, we need to recognize that as a surrogate outcome. So should we even really care about viral presence? It's not completely irrelevant, but we should actually demand impacts on patient important outcomes. Okay, so those 3 overarching questions: the quality of the trial methodology, what are the results, and how do we apply these results to our patients? In other words, was the science good? What did the science find? And so what? And I encourage you to use these tools on any piece of information, on a leadership article that you're reading, a newspaper article that you're reading. This particular presentation, I encourage you to ask whether did I do enough in order to present you a fair, balanced case. And I like to, imagine this fundamental exercise. If you were to do an ideal trial, how would you design it if you had a magic wand? And then think about, the piece of evidence that you're looking at. How does it deviate from that? Same thing with this presentation. Did I do enough to meet my own standard? I won't bore you with all this self-reflection and stuff that I was doing. Okay, and if nothing else, start with the GREAT approach. Randomized controlled trials, generally higher validity than observational studies. Be cautious whenever somebody's quoting an observational study with a lot of certainty. have more comfort when a randomized control trial is being performed. But that's just a rule of thumb, and I encourage you to think of all those other things. A couple quick thoughts just to wrap up. I think, when I was thinking about the stewardship group here and the fact that you're often dealing in infectious disease and pain and opioids, I feel like it's an area that's really tough to EBM in. The quality of research conduct will be disappointing relative to other types of medicine or healthcare. There are often small studies in patients that aren't our patients. And there's lots of unavailable or impractical interventions. The comparators are not adequate. They use lots of surrogate endpoints. This is just Zach's observations of challenges associated with EBMing in these areas. When you look at ID alone, geography is such an important consideration. And I think if you think of interventions that improve cardiovascular endpoints, they're relatively inelastic to the geography, not completely inelastic, but relative to infectious disease, where you've got susceptibilities and resistance and all that stuff that's so geographically determined. It's much more elastic and can move depending on the geography. The results might not apply to your local geography. Okay, a couple other tinfoil hat types of things. There's lots of industry disincentivization to research and develop quick-acting cures because the real money really is in chronic disease management. And then there's so many folks who are sort of have this nihilistic worldview because they figure that their interventions can't possibly improve things when there's such bigger problems going on. But that's all sorts of tinfoil hat stuff I'm not going to get into today. Okay, so we want critical appraisal to assist us with spin and dealing with that 17 years problem. And I didn't get into this, but this was just a point that, conflict of interest and industry sponsorship is something we really can't avoid. It's a reality that things are sponsored by the industry. We need to use the tools of critical appraisal in order to protect us against it. There's nothing we can do to say, there's really, I'm being nihilistic now, but there's really nothing we can do to combat this. There's always going to be industry sponsored stuff. That's how R&D works. That's how capitalism works. That's how the Western world works. So we just need to be able to be good critical appraisers in order to protect ourselves against those conflicts of interest. Okay. I had a couple concluding thoughts, but I'll just stop there because we're at the top of the hour here, a couple minutes after. And I'll hand it back over to Jason Van Soen, our host, for any closing housekeeping you need to do.
Thank you very much, Zach. I'm just going to stop the recording.